Our next speaker is Dr. Asim Ali, who's going to speak to us on the management of pediatric keratoconus.
Thank you for the opportunity to speak. These are my financial disclosures that are not relevant to this talk. Keratoconus in children can present as early as 4 years of age, and it often present at a much more severe stage of disease due to the fact that most children will not complain of even moderate to severe levels of vision loss, and these children are often picked up at screening or based on their refraction. It can often be associated with systemic diseases such as Down syndrome and vernal keratoconjunctivitis, as well as with eye rubbing and conditions such as Leber's congenital amaurosis and Turner syndrome. The diagnostic criteria are the same as adults. One of the problems is the lack of reliable topography or tomography. And this can be very critical, especially in older children or in borderline cases. You need very experienced technicians to get reliable readings. Tomography is difficult because children tend to chase the little wheel that spins around. And often topography is not possible. You have to make your decision based on both either pachymetry or keratometry in children who are delayed. Some of them require an exam under anesthesia. Retinoscopy can often be helpful, but it only really detects late-stage disease. I also caution you in patients with Down syndrome, they can often have thinner and steeper corneas at baseline, and in those who are reliable, these will often not progress. So don't be misled necessarily by slightly thinner or steeper cornea in these children. You need to make sure you follow them closely about every 3 months. Anecdotally, the progression can be much faster than in adults, but not in all patients. And unless you have a very clear history of progression, you need to be careful. Corneal cross-linking is approved in patients above 14, and below this is off-label. The criteria for treatment in children varies between studies, and there are many who advocate treatment after diagnosis without waiting for progression, and this is an area of controversy. Your minimum corneal thickness is normally 400 microns, but I'll often treat at 350 microns with hypoosmolar preparations, and this has been reported by other authors as well. One of the problems in many of the reports in the literature is that many of them only report 2-year or less outcomes. The longest term follow-up that's been reported was in 2018 by Mazzata and co-workers, and they found a 24% risk of progression at 10 years. And that means it's extremely important to follow these children in the long term because of the high rate of return of the disease. As an adult, you can get an improvement in Kmax by 1 to 2 diopters, an improvement in best corrected visual acuity of up to 1.5 to 2 lines, and you do get a decrease in your thinnest area by 40 microns. These are some of the changes we've seen in a 7-year-old who had cross-linking. At 2 years, the cornea is much more regular, and in fact, this effect has now persisted to 7 years after treatment, with no further progression of disease. Some of the cross-linking techniques have already been discussed previously. The trade-off for epithelium on versus epithelium off is one of effectiveness versus comfort. With epi-on, many studies show equivalence, but many also show inferiority in terms of progression in children. And my personal preference is to do epithelial off treatment because of how aggressive the keratoconus can be in this group, and sometimes how difficult follow-up can be as well. In terms of accelerated versus standard protocols, the studies are actually quite small, and there are really no significant differences between the two groups in head-to-head trials. In children, there have been short reports also of the use of iontophoresis and topographic PRK. Both have shown some success, but in very small groups of children. There's one case series of intracorneal ring segments that have been successfully used in children. However, if you read the paper carefully, they had a large rate of melts and removal of ring segments in children with atopy or vernal keratoconjunctivitis, and the authors do not recommend the use of these ring segments in these patients. Similarly, when I looked at retreatments, there's very little literature on techniques and criteria, and this has been poorly reported. The complications reported in children for corneal cross-linking are the same as in adults, with a rate of microbial keratitis at 1 to 2%. Sterile infiltrates have also been reported, and a haze rate has been described about 6% or less. And this is a patient of mine who had haze 1 month after cross-linking. The haze corresponds to areas of a persistent epithelial defect, and this faded over the next 2 months. Atopy and vernal keratoconjunctivitis are independent risk factors for keratoconus progression, which we all know. It's also a risk factor for microbial keratitis after collagen cross-linking, and we've had a case of MRSA keratitis in a patient with severe atopy. The other thing is that when you have active vernal keratoconjunctivitis, it can in itself cause topographic abnormalities which mimic keratoconus. And in these situations, you should treat aggressively and repeat the topography to make sure that these changes are real and to make sure the patient has keratoconus. Cross-linking is not the same as visual rehabilitation, and in many of these patients who cannot tolerate contact lenses, for example, will need to have surgery, or they will progress very late, and cross-linking is not an option. And this is a patient of mine who had DALK at keratoconus, is an autistic child who was very large and aggressive, and actually required anesthesia to make the diagnosis. The interesting thing is that after surgery, he wore spectacles and his behavior improved significantly, suggesting that the vision loss was part of his behavioral problem. In children, there have been good outcomes reported both with DALK and PKP, but there's no head-to-head or comparative studies. My preference is to do DALK in these children because of the greater tectonic strength and decreased risk of rejection that has been reported on just with the previous speaker. And there's a real advantage in eye rubbing in children who are eye rubbers, those with developmental delay, autism, and Down syndrome. And both big bubble and manual techniques have been published with good results. My own experience is with Down syndrome patients to strongly consider tarsorrhaphy to prevent persistent epithelial defects after surgery because of their floppy lids and behavioral problems. And a 1-week temporary tarsorrhaphy can really help start the graft off correctly. So in summary, keratoconus is often detected late in children and can progress quickly. Cross-linking is an effective therapy, but is associated with long-term failures, and these patients all need ongoing follow-up, which needs to be arranged and explained to the parents. Surgical therapy is often required, and I think DALK has a significant advantage in this patient population. Thank you.
Okay.